FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast, direto do Congresso Science 2023. A gente está sendo apoiado aqui pelo Curso BIZU. E estamos tendo a honra de receber um convidado internacional, o Dr. Lorenzo Patrone, vai trocar uma ideia com a gente sobre o novo dispositivo e as novas opções de soluções para a doença arteriosclerótica de membro inferior, que é o ShockWave. Lorenzo, you are very welcome. Thank you for joining us.
Obrigado. Thank you so much. Very happy to be here.
So, Lorenzo, do you have a new solution for huge and calcified lesions? And it is ShockWave. This is very new for us here in Brazil. So please introduce the device, the solution, and where to use it.
Sure. Yeah, that's definitely a device which is a new kid on the block for many people in the world. The first publication was in 2017, and 2019 he said it was published for the coronary. So one of the first times that something used before in the lower limbs before the coronary. So yeah. We should be proud of this. Yeah. Exactly. It's not that common. So essentially it's a very simple device for usage. Essentially it's a balloon and which has some emitters inside the balloon which are working with energy provided by a console. And this energy is creating microwaves, means like this kind of waves of, like a bit of an ultrasound, Uh-huh. And these kind of waves are targeting the calcium which is in the vessel, which could be the intimal calcium, the medial calcium, any kind of calcium which is around. The signal is very strong, but it's very limited to that zone. So essentially, it works very well on the artery. It doesn't affect any tissue around, so you can use it really everywhere. And it works for most vessels. So essentially, you can use it for iliac vessels in order to change the compliance and be able to deliver big devices like EVAR, TVAR, or TAVI. It can be used in the common femoral, which is an excellent option in order to treat calcified lesions without the need of stenting, or even to prepare the lesion to be stented correctly, maybe with a supera stent, which is, universally speaking, the best stent for this territory. And also, for the fempop segments, where like what they call the non-stent zones, the little tracks in the popliteal artery, P1, P2, where you don't want to put a stent or even SFA, because SFA is a vessel which is very mobile. So any place of the SFA is good for this device. And actually, as I said, you cross with the wire, it's an O14 wire. You pass this balloon, you inflate the balloon very, very gently, 2 to 4 atmospheres, not to create dissection. We need to come out a little bit our thought that the balloon needs to treat. The balloon is just the way to deliver the energy. Yes. So essentially, when you inflate the balloon a little bit, the emitters work, and then you crack the calcium. And always the people say, where does the calcium go? The calcium go nowhere. The calcium stays there. It just change. Of course, if you have a solid wall and you try to push, you can't really break it. But if you start creating little cracks in it, then it's easy to open it. So by creating these little cracks, and they're like amazing images with anatomopathological specimen or even with OCT or IVUS, then you change the compliance of the vessel. When you inflate the balloon, subsequent balloon, it could be a DCB or POBA, but usually DCB. But anyway, you inflate the balloon, then the vessel reacts in a different way. So there's no recoiling, there's no dissection. And this is also what the randomized control trial shows. Less need for stenting, 75% less stenting when you use ShockWave, with great results, with great patency at 2 years.
And are you associating with the drug-loaded balloons or just the ShockWave?
I mean, usually it's a ShockWave plus DCB in order to try to get the best of the two worlds. I have to say, if your practice has a little bit of difficulties in money, I think, you can avoid the use of DCB, but use the ShockWave. I think is a game changer, because the main thing with this very calcified lesion is not like the intima hyperplasia. These lesions go down in a week, in a day. It's very much related to recoiling, mechanical recoiling. So it's not, tissue which is growing again within the intima. So I think that the ShockWave is the game changer in this intervention. So to change the compliance, to make the vessel pulsating again. So what we are also developing is this kind of concept with some Italian colleagues, which is crack and check the wave. So if you start from a monophasic wave to a biphasic wave, then it means that you change the compliance of the vessel is pulsating again. The vessel is alive again, in a way.
Lorenzo, let me ask you something. Is ShockWave alternative to atherectomy, or you can use them both together?
Oh, that's a good question. Essentially, nowadays is my device to go for any kind of calcified lesions because of many different reasons. First of all, it can work in any kind of space, intraluminal and subintimal. And we know that most, or I would say all the devices, the atherectomy devices don't work in the subintimal space, are out from my view. First of all. Second thing, is a very easy device to use. Essentially, it's just, as I said, a balloon, and you press a button and the energy is delivered. You can ask your scrub nurse to do it. There's no prestige in using the ShockWave. And also the third and probably the most important reason is like the safety profile. So essentially, because you don't scrape, you don't pulverize, you don't sand the calcium, then you have a very good result in terms of distal embolization. So if you want to mention names, the Oak one from Medtronic is a great device. It's a razor. I mean, it really shaves the plaque, but it can create perforations very easily. It can create dissection. It can create distal embolization. So in the best trial, you have a 13%. I don't remember 13 or 18, but anyway, very high rate of distal embolization, even using the filter. ShockWave doesn't require the filter, and both the randomized control trial and the big observational trial with more than 300 patients, the rate of distal embolization is 0. It's not 1, it's 0.
Is there any case that you still use atherectomy, or the ShockWave replaced?
I mean, it's like the only cases where I use still atherectomy, I think, is the very long occlusion that you manage for some reason to cross everything intraluminal, very rarely. Then you can use like 30 centimeters. Then you can use maybe the jet stream. The thing is, I don't know if I'm allowed to say that, but ShockWave is coming out with interesting devices in the future. So they're already upsizing the devices up to 12 millimeters in order to deliver energy to vessels which are big ilex, and also they will come out in the next years with longer balloons. So I think that's the moment they come out with longer balloons, at least in my lab, in my lab, there won't be any more space for atherectomy.
Do you need to prepare the vessel before to use it?
That's a great question. Yes, I mean, it depends on what you're talking about. If you're talking about a stenosis, I would say no. If you're crossing like a chunk of calcium, a complete chronic total occlusion, because the device goes on an O14 wire in order to provide the lowest profile ever, and it's a bit of bulky because it's balloon with inside these kind of electrodes and all this technology, I always suggest to predilate for 30 seconds with a 3 millimeter balloon in order to create a little space to cross
just for the space.
Exactly, just to create a little tunnel where you can insert the balloon.
And it's allowed to use subintimal?
Yes, definitely. As I said, it can be used everywhere. And actually, there are two false myths that the device doesn't work in single calcified exophytic plaques and in a subintimal space. And I have cases to show that the device works in both spaces, and actually is a great tool. Even if you want them to stand, then you prepare the vessel really properly, and you change really the structure of the vessel. So
I think one problem here in Brazil, because for a multi-level disease, you have to use more than one balloon.
Yeah,
and we're worried about the price.
Yeah, but this is actually a false myth again, because essentially what we are saying, that the balloon is not the treatment. The balloon within the ShockWave is the way to deliver the energy. So, for example, let's say I have a popliteal or SFA of 7 millimeter, and let's say they have a TP trunk which is extremely calcified with the origin of the anterior tibial across where you don't want to stand, and the TP trunk is 4 millimeters. So, and someone would say, oh, you can't use a 7 millimeter balloon in a 4 millimeter vessel, because this is what we're used to think when we talk about normal balloons. But
you don't have to inflate it.
Exactly, because you don't have to go to 7 millimeters. You inflate to 2 atmospheres where the balloon is just a little bit inflated. It's very gentle, no barotrauma on the vessel, and you deliver the energy. That's the purpose of it. So 2 lesions in 2 different vessels, no problem.
You choose the device, you can use this like twice.
Yes, the important thing is to size it correctly, because the emitters needs to be as close as possible to the calcium. So if you, let's say, use a 4 millimeter device in a 7 millimeter vessel, then you have less results. So this is the suboptimal use of the ShockWave. So always, the company says size it 1 to 1. Sometimes I size it 1.2, 1.3 to 1. I don't mind. I can use an 8 millimeter device in a 7 millimeter vessel. I just inflate it very gently. I never go over 4 atmospheres. So be happy about the same inflation of the balloon, then you go with another balloon, and then you get the total inflation. Don't be fussy. Don't rush things. It's a delivery of an energy. Full stop.
One thing that I think is that the duration of the procedure is like not longer as if you use atherectomy.
Sure, yeah, definitely.
Yeah, it's
Especially they changed from the first generation to the second generation. Now we have, before it was one pulse, and so of every catheter has 300 pulse divided in 10 cycles. Okay, so essentially every 10 cycles the device stops. You can also deflate and inflate again. You can move it, and it's very important to say that the middle device, the middle emitter, is the one which has the most powerful signal. So essentially, if you have a single or particularly stubborn calcification, use the one in the middle to deliver the energy. But as I said, the first generation was like one pulse every second. So like was beep, beep, which was very annoying. Now it's 2 pulses a second, and actually it makes really a difference. Like beep, beep, beep. So it's actually in 15 seconds you deliver one cycle of pulses, and actually it makes it looks like stupid, but it made me so happy, to switch from one to 2 pulses a second.
It feels like it's working.
It's working. Like come on, like let's go. Yeah, exactly. So it's not like you need to wait forever. Yeah.
Lorenzo, I already did this question for you in our session, but I will repeat here. It's possible to use inside the stent, and it is possible to use in carotid artery.
Yes, I mean, this needs to be, I wanted people with ShockWave to cover their ears because I couldn't say that. But yes, it works also in stent restenosis. It's out from my view. But as again, it's not a device which is dangerous. So it's not like if you use it within the stent, it's not going to cause the stent to, I don't know, to make the stent hot or to break the stent or whatever. So it's very safe and it works. I've done a few cases, and also we discussed with other people that it's a use that you can use. And carotid, yes, I've done cases. Again, wherever there's calcium, ShockWave can work. It could be the SMA, it could be the IMA, it could be, even I used the 2 ShockWaves into the aorta with a great case. It was like a sort of a coral reef calcified lesion. And actually, I thought, any balloon mounted stent that I put, it will never expand fully. And because the aorta was not that big, I thought, I don't want to create more, drama, in the long term. So I'd say let's use 2 ShockWave balloons. And actually, the spine is a bit costly, but the result was amazing. So the stent, the 16 millimeter stent, opened fully. And actually, I took even 2 projections, the anterior and the lateral, to see really the stent, which was completely expanded. And this would have never been possible with such a tight stenosis. It was a pinhole thing with just a normal balloon mounted stent. So whatever there's calcium, ShockWave can work.
I had the opportunity to stay in US for 5 months last year, and I saw a surgeon procedure ShockWave in internal carotid artery using TCAR. So 2 devices that time we don't have here in Brazil. So it was fantastic. And he solved the problem. Very nice.
Really. I mean, think about all the sub expansion of the stents in the carotid, which could be, of course, the cause of a major intimal hyperplasia, which can be the cause of restenosis and potentially occlusion. If you use the ShockWave, it's more or less like the coronary field. The coronary field, they use the ShockWave. It's used massively in the world in order to prepare the vessel to expand the stent properly. But on the other side, also, we, with other Italian guys, we have this experience with ShockWave only in isolated calcified iliac arteries. So I say, okay, maybe we can start challenging the fact: do we really need to stent all of them? It's an interesting concept because angiographically speaking, sometimes it doesn't look that great because the calcium is still there, so you still see the a little bit of a shadow of the calcium. But then you get at 2 years, you get still patient which is asymptomatic with biphasic flow into the tibials. That means, okay, so before it was an occlusion, it was a monophasic, it's still very durable, and probably we can think about, stents in the iliac work well, but if you can use only ShockWave, maybe it's a better option.
Let me ask you something. The scars on the calcium, does it increase the risk of embolization?
No, I mean, this is interestingly not, because this is something that you can also think about, maybe, some pieces will move. But, my own experience, which is nothing compared to, I've done probably between 100 and 150 cases. But anyway, it's not like standardized as a randomized control trial or proper prospective observational trial. The embolization rate is extremely
You show
low.
us the microscopic photo in the presentation.
So, it's a little cracks, very little, very macroscopical thing, but they change the whole picture.
And as a take-home message, what would you finish your presentation?
No, I think it's a device which is really easy to use and has predictable results. So that's why there was a paper in 2020 saying IVL will change the market because it's easy to use and has predictable results. This, I think, is the most important topic if you want to explore with ShockWave. Easy to use, predictable results. So
Thank
use
you.
it in your practice wherever you are, and then you will see. I mean, it's not a fancy device. Everyone will have good results. This doesn't require skills. I think after 1 or 2 cases, you have a finish your learning curve. So yeah.
Thank you very much, Lorenzo, for your time.
Obrigado. Pleasure.
Não deixe de continuar acompanhando os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2023.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.